Well, hello. Welcome, everyone. My name is Scott Flamm, and I'm going to be your moderator today at a webinar. We'd certainly like to thank right off the bat the SCCT for providing this forum. And this is a session that is co-sponsored by PIA, Precision Image Analysis, and Keya Medical. And it's an effort to talk about how one scales cardiovascular CT services and implements CT-FFR within that process. So without further ado, I'm going to start moving forward and welcome all of you from, I'm sure, around the world, around the country, different time zones. Thank you all very much for making time to be here today. So the session that we have planned today is going to have a number of terrific panel members who will be introduced individually, but just as a quick overview. We have Dr. John Rumberger, who's the Medical Director and Director of Cardiac Imaging for Corazon Imaging. We're also including Ralph Gentry, who is the Director of Cardiovascular Imaging and Education at Precision Image Analysis. And last but not least, Mary Waiss, who is the Vice President, Market Development for Keya Medical. I think we're going to have a lively discussion, terrific presentation. Very much looking forward to it. I'm going to give just a brief overview of each of these companies because I think it'll be helpful to help set the stage. PIA, or Precision Image Analysis, is a leader in cloud-based medical 3D image post-processing, and they perform these analyses for regular clinical care at universities and networks of hospitals and imaging centers around the country, but also do this for research trials as well as clinical trials. PIA has remote, on-demand, cost-effective solutions with fully advanced image quantification, rapid turnaround, and full compliance with current industry standard security aspects. Keya Medical is a global medical technology company that is using AI-based medical analyses for diagnosing and treating diseases. Here today, of course, we're going to be talking about cardiovascular disease and specifically coronary artery disease. Yet Keya Medical does more than that. They provide clinical solutions that get into neurology, pulmonology, pathology, and even surgery. And their company is centered in Beijing, Shanghai, Shenzhen, and Seattle, Washington in the United States. And then lastly, Corazon Imaging is a relatively new company that is a healthcare startup using mobile CT-based diagnostic pathways for evaluating specifically cardiac, but also cardiovascular disease. They provide local accessibility with CT and CT angiography and incorporate fractional flow reserve analyses. And what's interesting about them, and really maybe an advancing wave for healthcare in cardiovascular care, is that their preferential referring group is primary care physicians who until recently have had limited direct access to cardiac CT and cardiac CT analyses. And Corazon provides individualized reports that also include individual recommendations that are appropriate for those primary care providers. So with that, I hope I've given you just a brief overview of each of these companies. And I wanted to tell you a little bit about our agenda today. Number one, I think this goes without saying that growth is challenging, and all of us continue to see this day to day. We think that outsourcing is a potential solution, and we will be talking about some of the benefits of that outsourcing through a variety of presentations, through our panel members, as well as some case studies that'll look at how CCTA and the integration and implementation of CT-FFR can be further beneficial. And then lastly, we're going to end up with a panel discussion, a bunch of Q&A, roundtable, where we'll dive deeper into each of these companies and these solutions for enhancing and advancing cardiovascular care. So as an overview, when we try to scale and increase both the magnitude and amplitude of cardiovascular imaging, it can be challenging. I mean, we all know that specialty cardiovascular image post-processing is challenging, it's difficult, it's time-consuming, and it takes a good amount of experience and expertise to really become good. And all of these things take time. And so that sort of time is challenging, both from the physician and the technologist perspective. But beyond that, it's also, this sort of growth can be challenging for our IT departments. They've got a lot of increased demand to be able to provide the digital infrastructure for this, send both data and analyses and reporting around to multiple sites. And it becomes challenging or further challenging when we have to scale down, because we know that there are bumps and ebbs and flows in cardiovascular imaging. And sometimes when we don't have as much volume, we'd like to scale down those costs. And you just don't have a way to do that in many situations. So I think today's discussion is going to talk about how using outsourced post-processing can alleviate many of these issues. And probably number one is that it's going to reduce so much of the time burden on technologists and physicians because it reduces the interaction with the complex studies and complex post-processing software to do those complex analyses. And some of the benefit of the outsourced approach is that it can provide rapid access to expertise, and it allows for the constant updating and use of cutting-edge, leading-edge post-processing tools and workflow efficiencies without having to put in that capital investment in all of the software, digital infrastructure, hardware and training, et cetera, that goes into it. And as a result of these things, it can also help reduce the burden and the effort of the IT personnel on an ongoing basis, because much of those IT issues are going to be left to the outsourced post-processing. And so this allows individual institutions or networks to be able to increase their portfolio of services by having so many more opportunities. And so some of the further benefits of outsourcing, again, is that it allows technologists and physicians to really do what they do best. And for technologists, that means not doing some of the post-processing work, but instead being able to engage in delivering direct care to patients and acquiring those diagnostic images. And also spending more time with the patient. And that helps increase CT scanner throughput, and spending more time with the patient increases that satisfaction. And for physicians, it allows them really to operate at the top of their license. And that can really be key in the environment we find ourselves today. It also can be helpful in that it shifts so many of the capital costs into operating budgets instead, which can easier to handle. Again, some of the outsourced and cloud-based services allow for continued and rapid updating of their software so that they are always at the leading edge of the software, never behind with last year's and 2 years ago software that may not be really cutting it with the sort of analyses that we want to do today. And it helps to speed up the revenue and keep pace with the rapid growth that we all see. So with that, I'm going to shift over. Well, I hope I've given you a general look at what we want to try to impress upon everyone today, and see if we can ferret out some of this information from our guest panel members. And right now, I'd like to shift over to Mr. Ralph Gentry, and he will be talking about cloud-based post-processing from the PIA perspective. And so I'm going to stop sharing my slides, move that back, and let Ralph come into play.
Well, thank you for that great introduction, Scott. I appreciate it as always. Hopefully everybody can see my slides now, and I'm going to start with the workflow for our PIA's cloud-based post-processing. And it all begins, of course, with the image acquisition that your technologists at your site perform. And these image data sets can be sent either directly to the Ombra gateway at your site, or from your PACS to the Ombra gateway, which then go to the PIA cloud, and it populates to a work list for all the analysts. And then we perform the designated analysis, usually for coronary CTA as far as this goes, this presentation goes. So the clients first, and this is a little case study of how it would go. The clients first send all the CTA exams to PIA right from your scanner. And then PIA identifies the patient study meets the physician designated criteria for further analysis, CT-FFR as the example here today. PIA then forwards the study to Keya for FFR analysis, and Keya returns that study back to PIA, and the results then go through the cloud back to the client's PACS. The physicians then interpret the study as part of the normal workflow or the usual workflow. As a single vendor source, PIA charges the client for the studies sent for post-processing, including the FFR analysis. This is the workflow chart of how that would work with a CCTA combined with a CT-FFR. The client sends the exam, just as we described before, to PIA through the cloud. It then undergoes analyses by the analysts at PIA. It either meets or does not meet a predetermined set of criteria that the physician sent. If it meets that criteria, PIA then sends it off to Keya Medical for analysis. If it's borderline, then we consult the physician that requests the CT-FFR. Once we receive the results back from Keya, it then goes from PIA back to the client. And then the physician reviews the entire study, both CCTA and CT-FFR at the same time.
All right, well, Ralph, thank you very much for that overview. Now we're going to switch over to Mary Waiss, who's Vice President at Keya Medical, to tell us a little bit about a little more about Keya Medical's offerings and some of the data behind them that supports the use for CT-FFR. Mary?
Thank you, Scott, for that kind introduction. It's my pleasure to be here to talk with all of you today. I am Vice President of Market Development for Keya Medical. As Scott mentioned earlier, the company it's an international medical device company with applications for many specialties. I'm here to talk to you today about our flagship product, which is part of our cardiovascular suite. The flagship product is for CT-FFR, and we call it deep vessel FFR. This is the output from our product. Company's had a rapid journey. It was founded in 2016. We received the CE mark in 2018, Chinese FDA in 2020, and FDA clearance in 2022. And as you all know, getting this type of regulatory clearance requires extensive validation and research projects to support the regulatory approvals. Some of the data from those studies I'll share with you. The first is the ADAPT study. This was a multi-center international study in which we validated the results of the deep vessel FFR product against the cath lab invasive FFR. And you can see that the results were quite good. The target rate set for the study was 75% for sensitivity, 70% for specificity. And you can see that we well exceeded those goals. We achieved FDA clearance quite readily and have had the FDA clearance since April of last year. Some of the other studies that supported other regulatory approvals, this study was done in 2017. The product has evolved over time and the results are even better today, but you can see, again, accuracy, sensitivity, specificity, and in a nice range that supported regulatory clearances. Also, we had the opportunity to have one of our researchers, Dr. Yunde Shen, present this year as late-breaking science at ACC, her work using our product for on-site CT-FFR. And her study showed, it was a large study from 6 centers in China, 1,200 patients, and essentially showed that patients with stable coronary artery disease and an intermediate stenosis of 30 to 90%, the on-site CT-FFR could cut down on unneeded angiograms while catching obstructive coronary artery disease, which might otherwise have been missed. Our product uses deep learning neural networks to calculate the CT-FFR. Quite a few benefits from that. Uses less computational power, performs the analysis in minutes, and future iterations improve, the performance improves with more data. And we're getting nice feedback from our current clients about other advantages of this deep learning neural networks, which anecdotally we're told the rejection rate is lower, and it can actually do analyses in situations where other solutions may not. And with that, I'm going to turn this over to Dr. Rumberger, who we are quite pleased and honored to say that he's one of our early clients using the product. Dr. Rumberger has over 500 relevant peer-reviewed publications in this space, and we're looking forward to hearing his comments on the product and his use of our solution. Thank you.
Okay, excellent. Oh, let's start that up. Hi, I'm Dr. John Rumberger. I'm the medical director of cardiovascular imaging at Corazon Imaging. I've been involved with cardiac CT since its inception in the early 1980s. But I've been aware of about a decade of the FFR CT, but I had personally little or no experience in using it on a clinical basis until joining Corazon Imaging about a year ago. I want to share my thoughts on FFR CT and give some insights into 2 quick cases. I want to remind you, however, that the importance of cardiac CT. Over the years, we've been very dependent upon cardiac catheterization, and in my opinion, I believe that CCTA has now become the reference standard for looking at coronary arteries. So unlike conventional angiography, which is a luminogram, the CCTA allows one to see the entire vessel in cross-section or longitudinally along its path. Thus, rather than looking at discrete stenoses and the pressure gradient across that stenosis, it allows one to look at pressure drops and gradients across the vessel as a continuum. The benefits of looking at CCTA-derived FFR is that you get a 3-dimensional map of the pressure changes, proximal to distal, across all epicardial vessels. Thus, you can determine pressure loss across individual stenoses or multiple stenoses in the vessel as a whole, and evaluates the vessel again as a continuum, not as a single threshold. Also, as someone who's been trained formally in coronary physiology, I like to think how FFR can relate to the physiologic flow reserve. And I keep in mind this little chart that I created. An FFR CT of greater than 0.85 implies a flow reserve in that coronary vessel of about 3:1, whereas an FFR CT value of 0.6 or lower is consistent with a flow reserve of about 1.5:1, which, if you can recall, would be consistent with early positive traditional ECG stress testing. Here's the first example. This is an 84-year-old man who's had chest tightness and dyspnea has a history of heart disease, and previous to this has no known heart disease. The results of our study showed a normal ejection fraction, no regional wall motion abnormalities, no evidence of left ventricular hypertrophy, and an aorta that was about 32 millimeters, which is normal. These are the images. The upper shows the left anterior descending, and the lower shows the right coronary artery. Now let's look at each of these vessels individually by looking at the FFR situation. Shown here is the three-dimensional map of the coronary artery tree. And we'll begin here. It shows the FFR up in the upper right and the vessel diameter. You can see it began somewhere around about 0.93, but as we go down into 0.81 and finally down in the distal left anterior descending, we see a value of 0.73. So this represents a total pressure drop across the vessel as a continuum of about 23 millimeters of mercury, which is considered physiologically significant. This is the right coronary artery. So I move the three-dimensional map over. Again, you begin with just proximal to the area, somewhere around here. It's about 0.94. You see this lesion, and distal to that lesion, it ends up being somewhere around about 0.89 or so. Moving down further, then we can see that this becomes about 0.80 in the mid vessel and distally about 0.74. Now, a very interesting observation that I had personally not made is that when reviewing the 3D map on this particular case, this is showing the left circumflex vessel. And in the region of the second obtuse marginal vessel, you can see that there also is some evidence of potential ischemia with an FFR of about 0.74. All of these were verified in the catheterization laboratory, and the patient was sent for a successful bypass surgery. The next case is a 59-year-old man who has dyspnea, anxiety, and fatigue. He'd been a heavy smoker in the past. Again, he has no known previous heart disease, normal ejection fraction, normal left ventricular mass, no regional wall motion abnormalities, and a normal aorta. As we look here in the lower area, you can see that there's a discrete stenosis in the region of the mid left anterior descending. So this is the kind of traditional thing that you think of FFR being used in CT as well as in the cath lab. When that was done, here's the vessel again. The benefit here is an additional reconstruction done by the artificial intelligence, which frankly sometimes is better than my own reconstruction and definitely complementary to these findings. And in this particular case, the FFR was 0.82, which we consider to be non-ischemic, and the patient was then just sent home with reference for aggressive therapy in terms of lipid and hypertension. Thank you for your attention, and I look forward to the roundtable discussion. Did not.
Thank you, Dr. Rumberger. Let's see. All right, there we go. All right, let me get my video back on. And here we go. Terrific. Okay, so we've got our Brady Bunch kind of gallery up here. And Dr. Rumberger, Mary, Ralph, glad to have you here. This is the part of the presentation where it's a roundtable. It's a Q&A. And I've got a number of questions that I'd like to ask and throw out, but I also see a number of good questions coming in through the Q&A and chat areas. So actually, Dr. Rumberger, since you just finished talking and gave us some illustrations of how this is the tools, both coronary CTA and CT-FFR, are beneficial in triaging patients' care. Let me ask, how you've been doing this for a number of years now. How has CT-FFR impacted your practice? You know, what sort of changes have occurred? And well, I'll leave it at that.
Okay, well, thank you, Scott. Frankly, it's been a game changer for me and my practice. Having access to FFRCT has allowed me to shorten my overall interpretation time significantly, because I recognize in the past we would spend minutes, perhaps hours, staring at lesions, twirling them around, looking at them, saying, gosh, I think this is obstructive or not. And this allows me to say, listen, let's just get another opinion, artificial intelligence. And it allows me to improve my confidence of what we're doing. And then when ischemic potential has been identified, I frequently put the sample of the 3D images into my report to assist my interventional cardiology colleagues during invasive angiography.
Well, let me follow on with that and say, you know, we have a general understanding that a coronary CT angiogram that has minimal or mild disease probably doesn't need CT-FFR, and those patients who have severe disease are likely not to need it either. And it's really that relatively broad intermediate range where it can be most helpful. I'm interested in understanding how frequently you get surprised when you've got a lesion and you say, well, it's in that moderate range, but I'm pretty sure it's severe. You know, how often does it turn out not to be? And then vice versa.
That's an excellent question. And I can tell you that we do an awful lot of studies, but at least weekly, I get surprised one way or the other on these situations. But again, what it's done is improved my confidence in what I interpret, so I can feel good about saying, listen, this is absolutely not obstructive. Let's not do any further situations. So again, it adds to my education along the way. So it does happen. You know, sometimes I'll say I'm not surprised, but I'm glad to have the confidence to be able to provide this information to my referring physicians.
Yeah, terrific. Okay. Well, let me segue in, and I just gave sort of a general assessment of where CT-FFR would come into play once you've got a coronary CTA in front of you. But that may not be correct. Could you elaborate on what are really the triggers for you to ask for an additional CT-FFR analysis on the coronary CTA that you're looking at?
Well, I generally use what the American Heart Association, American College of Cardiology has suggested. Visual stenoses between 40 and 90%. Frankly, if you look at them compared to physiologic measurements of blood flow, which were done many years ago, there's like a shotgun. So you can find lesions that appear visually to be 40% that are terrible, and you can find lesions that are 80% that you say, gosh, this is really not much of a pressure drop. So it's very important. So I basically stick to the rule. Once it gets into the 40 to 90% stenosis, I pretty much standardly go forward with respect to the FFR. Additionally, I've also learned over the time that when we do coronary calcium scores, which we do on every patient, once the individual calcium score, especially in the proximal vessel, is over 300, I know I'm going to have a problem that without having some additional artificial intelligence help.
Yep. All right. Well, how about a next question that's really both to Mary and to you, John, and that is, we understand that there's an additional charge, an additional compensation reimbursement for a CT-FFR going along with those additional codes that are out there. what is happening out in the field? What is that like? Are those being met with challenges by insurers and others, or is this running smoothly? Where are we today in routine clinical care?
Well, at least in our practice in Michigan, we have been very successful. That primarily, most of our patients are Medicare age or slightly younger along the way, but we take anybody along the way. We can do it even if you're Medicaid rather than Medicare. But it works out very well. Some insurance companies will not reimburse a cardiac catheterization. They'll say, let's do a CCTA. And then in some instances, in Michigan in particular, they will not approve a CCTA unless the facility also has the ability to do FFR CT.
Fascinating, fascinating. So, Mary, how about from the industry perspective? You're in that position. What is Keya Medical seeing out there, talking to their folks? And I'll preface this with saying that we understand that this is a dynamic situation, and reimbursement and coding and acceptance of this is something that really is changing in front of our eyes. But what is it like out there today?
Well, our other clients are having much the same experience as Dr. Rumberger. The billing is going quite smoothly for them.
Fantastic. That was short and sweet. Okay.
Not much to add to that, other than to say it's working. They are able to bill to the codes, as is Dr. Rumberger and Corazon.
Okay. Mary, let me stick with you for a moment. When we know that the quality of studies can be variable, and am interested in understanding, what percentage of studies that come to Keya are able to be successfully analyzed, and what are the limitations to that? What sort of studies do not get fully analyzed? So
I should have shared my slide that shares the inclusion criteria, exclusion criteria for the FDA clinical trial. We request that our clients follow the same guidelines as recommended for SCCT for the image acquisition. Certainly those patients that have excessive calcifications, other reasons for rejection are excluded. That being said, the rejection rate for the clinical trial was 14%. And we're told from our clients that the rejection rate is actually, quite a bit lower. And again, anecdotally, as I see the cases go through, we've seen only a handful that have been rejected from those hundreds of cases that we've analyzed so far since we launched earlier this year. And so anecdotally, the rejection rate is quite satisfactory and pleasant surprise to our clients, and the results remain good, as you can see from the data that I shared earlier.
Yeah. And could I query you just a little bit more? There are a number of ways for a coronary CTA to not be so great, and that can include patient size, suboptimal contrast enhancement, stair-step artifacts, arrhythmias, lots of calcification in the vessels. Which of those, or which combinations of those factor greatest into the rejection rate?
I defer to the analyst team on this. They see thousands of these cases, and when they see the cases that, and it can be for a variety of reasons that they will reject a case. And sometimes it's motion artifacts, sometimes it's calcification. It really varies. And again, it's the analyst team. The first step in the process is that the analyst team will review the quality of the images and determine if analysis can be done, and then proceed. So they have a list of criteria that they evaluate and use that against every case. And I should say that the cases, they view the cases on the AWS servers in the US.
Is there a, staying along this line of sort of the technical aspects, is there really a baseline CT system or scanner, what are the characteristics of it that Keya thinks is a minimum to be able to do a quality study that can be analyzed? Well, number one, just the acquisition right up front, and number two, successful analysis with CT-FFR.
Certainly the all of the current all the large manufacturers with their current systems generate images that are more than satisfactory for our analysis. We do require a 64-slide scanner. And yet again, most of our clients, all of our clients, have the equipment that can generate the images that are appropriate. And we have clients from around the world that are sending us cases, and they all have scanners that meet the requirements for analysis.
Okay. All right. Ralph, I've left you out so far. My apologies. Let me come back to you. Can you tell us about some of the IT needs, digital infrastructure setup that would allow PIA to get studies from clients? I know you touched on that in your slides, but could you talk a little bit more about that and what the typical IT department needs to do to be able to integrate this process?
So there are two main things that we always ask a client when we start to onboard them. The first one is, do they have Ambra on their network already? If they already have Ambra network in place at their institution, it's pretty seamless. It's about an hour to set up a gateway with our IT folks at Precision Image Analysis to test with image transfer and then report and reconstruction transfer back to the site. The second one would be if they don't have Ambra on their network, really the big lifter there would be to spin up a VM, a virtual machine, that the gateway is then installed on their network on this virtual machine, and then the same process is followed. They set up a gateway between PIA and their institution, so the flow of data comes to us seamlessly and then back to them. So overall, it's really seamless for IT departments. And I saw a question on the chat about security, and that was touched on in the presentation as well. PIA is compliant with all the major security, SOC 2, HIPAA, etc.
Well, thank you, Rob. Let me stick with you, and I'm going to circle around and get Dr. Rumberger and Mary involved in this question as well. And that is, so when a study, coronary CT, comes to you, and you determine that it needs or that it meets threshold to get a CT-FFR accomplished, tell us about that process, and what are the steps that you need to do to make that happen? Is there anything different that the client site needs to do to make this happen? And what is the sort of turnaround time? How long does it take for all of that data to come back and go to one of PIA's clients for a coronary CTA with FFR analysis?
Well, I'll speak to the imaging workflow part of it. Usually ahead of time, as we onboard a patient, we will meet with the physicians and set up either predetermined criteria where we can just send this data to Keya for analysis, or if it's questionable, and I think that was mentioned in one of the slides in the workflow charts too, we contact the referring physician to see if they'd like, or they ahead of time send an email that says, we want this patient sent for CT-FFR. So we do our regular analysis of the coronary arteries and then send it off to Keya for analysis. And that method is handled the same way. It goes through our Ambra gateway to Keya, which was established as we became partners with Keya. And we send out an email to their analyst that says, we have sent X case to you for analysis. Please verify receipt of the case. And then we get email notification when the results are returned to us through the Ambra gateway as well. And then we just pass the data back on through that same gateway that we talked about back to the client. And then I know Keya is working with turnaround times, and I'll let Dr. Rumberger and Mary comment on that part.
Let me just jump in here really quickly, Dr. Rumberger, if I may. Until now, like I said, we launched the product earlier this year in the US and have been scaling ever since. Our guaranteed turnarounds have been 24 hours. That said, Dr. Rumberger and others are asking for a more rapid turnaround. And in fact, we just launched that this week. And I haven't even had a chance to let Dr. Rumberger know that our stat turnarounds are now available for your team. And so we are growing that and scaling as we grow the business and the clients in the US. And we're able to improve our service, shorten the turnaround times, move analyst team to the US, and are even offering on-site analysis for those centers that have volumes to justify that. And that turnaround, as Dr. Chen pointed out in her ACC presentation, was just a few minutes. And so turnaround times are variable.
Wait,
and,
did you just say?
depend on the
Did you just say a few minutes, Mary?
I did, and I'm
Wow,
quoting
okay.
Dr. Chen, who said that as a response to a question at ACC. I would not say that if someone who was
Okay.
using the product was not her experience. But again, that's the benefit of the deep learning neural network solution, that it's quite rapid in performing the analysis. And that was certainly her experience with the on-site solution, that it was quite fast, and certainly getting the results that quickly made a real difference in her point of care with her patients.
Okay, John, let's come over to you. What's your experience?
My case, I analyze the calcium scoring. I try to make the appropriate images, reconstructions. If I feel that I can't do it, I don't think AI can do it. If they're just not satisfactory, I'm not going to send them. So our rate is 0, because I don't send off crappy studies, but we do excellent studies 95% of the time. It's 2-button clicks. I basically click on the patient images, and I click to send to the Amber Gateway. It's immediately sent, and then the results, and Mary, you're quite right. Yesterday, just yesterday, I sent 2 studies, and I got them back within hours. So that's been fantastic.
So it sounds like things are getting faster, which is always nice to hear.
Faster.
You know what? You know, something that just came top of mind is that, you know, Keya started in China, but now has offices here in the United States, and talking about analysts being here in the United States as well, and can be at individual sites with sufficient volume. But how about the other way around? Ralph, does PIA do analyses for sites outside of the United States?
There are 2 clients that we have outside the US. One is in the Middle East, and the other is down under. But we have serviced for the research that you mentioned earlier, Scott, from outside of the US as well, yes.
Okay, so the simple answer is yes. Sites that are outside the United States can certainly get processes through PIA.
Correct.
Okay, all right. Ralph, let me stick with you for a moment. I think you touched on this, but if I could ask for just a little bit more clarification, how long does it take for a new client to come on board? I mean, let's assume that all of the financial contractual stuff is accomplished, and if everything's a go, you know, how long does it take to set up the infrastructure and get data from a client site to PIA and then turn back around?
So we have a couple methods to do it. When we have prospective clients, we use a one-time Amber Gateway link so they can see the quality of precision image analysis work. The other is mostly dependent on a institution's IT team and their availability. We're ready to go right away as soon as the contract is signed and a meeting can be set up with their IT team. So it's really a matter for the time, Scott, the availability of the institution's IT team. And that can vary greatly. A lot of these IT departments are very busy, especially at bigger institutions, but even at the smaller institutions. So it is variable, but PIA is ready to go basically when a contract is signed.
Okay. And Ralph, I'll stick with you. Tell us about the analysts that PIA has, the people who actually do the work on the images, do the post-processing. Where do they come from? What is their background? I'll leave it there.
So the majority of the analysts, myself included, because I am one of the analysts as well, as doing webinars and other such things, are RTs, certified RTs through the AART, as well as some biomedical engineers. And it's a good combination of both. And there is a strict training process where all of the analysts that come on board, which is rapidly growing because of our client base is rapidly growing. And Scott, you're included in some of this training as well, as you know. They have to meet certain criteria and gold standards for these certifications. And there's nothing that leaves PIA back to the client that doesn't have a second set of eyes, and second set of eyes to look at reconstructions and measurements, et cetera, are usually one of the senior analysts that do that.
Terrific. Okay. And does PIA typically have some individual sites, or does it have larger universities, networks of centers? Tell us a little bit about that.
It's really a combination of all of those. It comes from imaging centers to large academic institutions and everything in between. So, and then there's a variety of requests for different type of non-coronary or cardiac analyses starting as well. So we're starting to grow our product line that way as well.
Okay, super. I'm going to circle back around to some payment issues. We've got a couple of questions about that in the chat. And the question really is, what's the process for the billing of the patient or the billing for the patient when a CT-FFR is accomplished? Where's the decision-making point, and are there any additional steps and hurdles along the way? And I think this probably is a very good question, one from a site that hasn't yet implemented CT-FFR and wants to know what they need to watch out for along the way.
Given that Dr. Rumberger has personal experience with this, I'd like to put this to you to talk about your personal experience with the billing, if that falls under your wheelhouse as the medical director.
Yes, well, I mean, occasionally I will have to make a preliminary report where I request that the DV-FFR be done. But most of the time, I don't have to do that. We have the physicians ordering the test with DV-FFR as an option. We use then the billing code 75574 for the CTA, and we use a billing code of 0501T for the FFR analysis. And I believe that this has been very satisfactory in virtually all of the cases where this is justified. I justify it in the report, so whoever's looking at it's going to say, why did you do this? So that's actually part of my added situation. But we've seen, I think, excellent reimbursement, especially in the Medicare clientele.
All right. Question for both John and Ralph. And that is, when there's a new site or a new client that comes on board and they really haven't done much cardiac coronary CT to this point, how is the quality assured, quality of acquisition and training getting done, protocols? Tell us a little bit about how all of that gets put in place to help improve or maximize that relationship between Corazon Imaging, PIA, and their associated sites.
First of all, you get the best technologist you can find. As I've always said, a surgeon is of no value unless he or she has a proper circulating nurse. As far as I'm concerned, the technologist is the nurse. That's what gets things done. We have frequent conversations and discussions, but the idea is getting a technologist that has experience or making sure they have experience. And SCCT actually offers that kind of webinar for training for RTs. So we use that. We use my own protocols, but frankly, an experienced nurse or an experienced RT is the primary driver for our success.
So thank you for the compliment being an RT, Dr. Rumberger. I appreciate that and couldn't agree with you more. So at Precision Image Analysis, we do many things for that. So we get the protocols from the physicians as we begin an onboarding process. We also recommend if we sense that there's newer technologists on board that they go to the SCCT website and look at the current guidelines and follow those guidelines when they do their acquisitions. But also personally, I've been on site visits with our clients to help the technologists both with cardiac MR and coronary CTA, first to observe and see the process, see what they do. As everybody knows on this webinar that, the manufacturers come out for a applications training on certain devices on their CT scanners and MR scanners. So it really needs to go beyond that because this, as you mentioned, Scott, is an area of great expertise. And there's a large learning curve. So PIA offers on-site training, usually myself, but other technologists as well that will go to the sites.
All right, thank you. I see another question in the chat, and it has to do with plaque analysis, and certainly stenosis, the plaque composition in a qualitative, subjective sense, being non-calcified, calcified, mixed. These things are sort of commonly put into reporting, but CT-FFR takes us to another level, and know that certainly some of the companies out there have plaque analysis tools available that can dig a little bit deeper than the subjective qualitative analyses that the human eye puts into reporting. So I wanted to ask, number one, does Keya have some of the plaque analysis available? And if not, is that on the horizon? And John, I'll come back to you and ask how important do you think that is? So I don't want to jump the gun, Mary, if you'd answer first.
Scott, you've heard the teasers about the next version of the product that's coming out. It's really quite elegant. I'm looking forward to bringing it to the market. The next version of the product does have plaque analysis. Also has is expected to have fat attenuation index available in the next version of the product, and a host of other upgrades and features that are quite compelling and elegant. That's not yet available in the US market. We don't have FDA clearance for that product, but that's coming. So thanks for asking the question. And I'll turn this over to Dr. Rumberger to answer part two.
I've had the pleasure or experience of actually being one of the first people in the United States to actually use advanced plaque analysis artificial intelligence. And I can tell you right now that it definitely adds to the overall situation. It has taught me to be more careful because sometimes I would look at a lesion and I'd say, I think that's probably normal. And then if you look at it more carefully, you say, there might be something in here. That becomes very important. So it has taught me to become more cautious. I think as we develop these tools and make them more standardized, they're going to be just another additional game changer for the whole use of artificial intelligence in cardiology.
All right, super. Thank you. Listen, we are coming close to the end of our time, and I know I've asked a number of questions and corralled a number of them from the chat and Q&A portion, part of the application. I wanted to ask you all, are there questions perhaps that I didn't ask or that the audience didn't ask that you think would be important to talk about? You know, are there things that are critical to what each of you does on a day-to-day basis that can really advance and enhance the coronary CTA world and those healthcare providers?
Well, I for one, it speeds up the process. Speeding up the process prevents me from getting a little too tedious, spending, oh gee, it's been 50 minutes and I'm still looking at this lesion. So it's something that just says, listen, move on. This looks serious enough to send to somebody else. Get it done. Now that I get the results back in a couple hours, that's pretty satisfactory. So I think it really has significantly improved my ability to read more rapidly. It has allowed me to read more confidently.
Mary, anything else?
You know, I guess I'd just like to add that it's our goal to get this important tool in the hands of the clinicians like Dr. Rumberger and his team by making it more accessible through partners, integrating into the workflow easily with a partner like Intelerad Ambra, making the pricing acceptable and workable for the patients and the reimbursement. So the goal for Keya Medical is to make this a practical tool in the toolbox of clinicians that are taking care of patients with coronary artery disease.
Ralph, any last comments?
Yes, sir. From the PIA perspective, I'm going to echo what Dr. Rumberger said, and that is, you know, we take a lot of the load off of the physicians and technologists' hand. That was covered in the slides a little bit, but I can't stress how important that is, both for patient care and for staff care and staff retention. So those are the main takeaways. And then becoming partners with Keya, whether a client just sends us a coronary CTA for processing, that alleviates a lot of that time. And then the addition of FFR with our partner Keya, it just enhances it even more, as Dr. Rumberger said. So.
All right. Well, listen, thank you all very much. I'd like to thank all of the audience for listening in today and providing us with such great questions during our roundtable discussion, and really would like to thank Dr. John Rumberger, Mary Waiss, and Ralph Gentry for being here today and going through the steps for coronary CTA analysis and incorporation implementation of CT-FFR and all of the digital infrastructure aspects that we have to go through. I really thank you all very much for being here. It's been a real pleasure, and we look forward to doing this again sometime soon. And with that, we will close.
Thank you, Dr. Flamm.
Thank you.
Pleasure.